Can everyone see the slides okay? Okay, great. So this is a little intro to members of our team. Some of them who are here, some of them cannot be here. So this is our surgical team. So Dr. Kate Walla, who's the chief of our Abdominal Transplant Institute. Dr. Jay Graham, who's the surgical director of the kidney side. Dr. Moody, who's the surgical director of the pancreas side. Dr. Hillary Yaffe, who's over here. She's the director of the Transplant Fellowship Program. Dr. Marie Lay, who's the surgical director of the Donor Kidney Program, and Dr. Dagny Van Aarons. On the nephrology side, so Dr. Ember Acklin is our medical director of the kidney side. Dr. Maria Jaime is the medical director of the pancreas side. And then the rest of our colleagues, Dr. Yorga Z, Dr. Luz Liriana Ward, myself, Cindy Painadit, and then Dr. Swati Jain. So what we hope to accomplish today is to go over some of our program highlights, go over the referral and evaluation process, some of our inclusion-exclusion criteria for transplant candidacy, discuss briefly some of the data and discussion about how the UNOS waitlist works, how we collaborate for care and communication, and briefly about our living donation program. So we've done more than 4,000 organ transplants since 1967, with roughly 1,000 of those transplants being done within the past 5 years. We're one of the largest transplant centers in the US by volume, one of the most comprehensive transplant centers in the US. We have many dedicated resources for our transplant, including a strong children's hospital, transplant outpatient center, as well as inpatient center, and also housing assistance on campus for international patients. So we performed 350 total adult pediatric transplants over the past year, and we conduct over 250 kidney transplants each year. It's important to note that over the past 5 years, we have been surpassing this number every year, and we are consistently growing our program. So a little bit about UNOS, which is United Network for Organ Sharing, and the wait list. So there are over 100,000 men, women, and children who are on the National Transplant Waiting List waiting for an organ of any kind. There's about 90,000 of those on the kidney wait list. In New York, almost 8,000 New Yorkers are currently on the National Transplant Waiting List, with approximately 7,000 of them waiting for a kidney. So you can see that the need for transplant is definitely there, and this number is growing every year. So we know that life expectancy for patients who remain on dialysis is shorter than those who have a successful transplant. You can see that by the graph over here. In orange, this is the expected life expectancy in years while staying on dialysis, versus you can see in the blue if they got a transplant. And you can see across all age groups, there is on average about 2.5 times more remaining life years expected for patients who get transplanted versus if they stay on dialysis. So the wait list is not really a list. There is definitely a complex system that generates this list, and it's comprised of information from the transplant program. So at listing, the patient's information presented to UNOS, including age, cause of ESRD, their height, weight, and other features of them, including their time on dialysis, their blood type, their location, and many other features. Similarly, on the OPO side, when we have a donor offer, that information is placed into the UNOS system, different qualities or characteristics and identifiers for the donor, and that's put together to generate a list, as you can see at the bottom. And candidates that are screened out are not in that list, and candidates who do meet the matching criteria do pull up on this list. So you can see an example of this list here. So this represents our region. So our patients will be mixed among other centers in this same OPO. So as far as the referral evaluation process, so when should patients be referred? Always. We would rather have you help us make the decision and educate the patients rather than trying to decide on your own. So when treatment options are discussed for ESRD, that's a great time to also give the patient the option for transplant while you're discussing also dialysis as an option. Ideally, we would see them before they start dialysis, whenever their GFR is less than 25. And our goal is to transplant them either preemptively, meaning before they start dialysis, or early transplant with a living donor. The patients who transplant preemptively or in early years of being on dialysis, those patients tend to do better because they have stronger base and they're less sick. So as far as the referral process, so there's a multidisciplinary approach to what we evaluate, but the steps in terms of getting the patient over to us is first we review their insurance, they get a brief phone screening. We aim to have the first contact with the patient within 72 hours from receipt of the referral. And then we do a follow-up correspondence with the referring physician and or the dialysis unit. Our target is to have the patient scheduled for a referral evaluation within 4 weeks of the initial referral. So again, the steps, so we first have the patient referred, then they attend a transplant educational meeting. So that's done on the referral, on the evaluation day. They complete a pre-transplant evaluation. They have the patient's information is presented at our multidisciplinary meeting. Then they're listed after the workup is completed. They're listed for deceased donor, and we evaluate their living donor candidacy. Once they have the transplant, then we follow up with the post-transplant care. And we are working to improve and increase our communication with the referral center so that we can work together to take care of our patients. So on the evaluation day, what does that include? We have a transplant coordinator who's kind of the main person who is coordinating all of the evaluation for that particular patient. They do the education and they do the initial assessment for the patient. The patient will also see the transplant nephrologist who will do a medical assessment, a brief introduction to transplant to reinforce some of the key points that are important to know after transplant, talk about immunosuppression, and also infection risk and infection prophylaxis. We have our transplant surgery colleagues will also consult on an as-needed basis if there's any surgical concerns or if there's any other concerns about patients, such as an elevated BMI or something that could make them a surgical complex patient. We have our social work evaluation, our financial counselor interview, our living donor coordinators will meet with the patients. The patients will get some basic lab work needed for transplant, and then we just, again, reinforce the education with the patients.
So I'm one of the financial coordinators. My name is Samantha Ramirez. So prior to the patient actually being seen for the evaluation, once they're scheduled and we see, okay, this week, these are the patients that are coming in, we run the patient's insurance. We check to see if there are any out-of-pocket costs, to see if they also need a secondary. So we want to make sure that at evaluation day, we have all of this prepared. During the evaluation, we sit with the patient, we discuss their benefits. We also check their drug coverage to make sure that their insurance does pay for these medications, especially the immunosuppressants. We also go over their finances, see if they're in any HRA benefits, if they're on dialysis, because if the patient is on dialysis, they may qualify for Medicare. So we go deeply into the financial aspects as well as their insurance, just to make sure that they have adequate coverage for the transplant, post the transplant. Now, while the patient is in the evaluation phase, we do keep checking the insurance, and we also tell the patient if something changes, please let us know, because a lot of these insurance companies, they do need authorizations, whether it's for evaluation or for listing. We do talk to the doctors and the coordinators regularly because some insurances need certain testing done in order to obtain these authorizations. Once the patient's listed, we also check them monthly to ensure that everything is still the same, because we want to make sure that when the patient is called for an organ, an authorization is on file, they're good to go.
So next, they meet with the social worker during the pre-transplant evaluation day. Really what we're looking for is how we can prepare for recovery. This is a conversation we're having oftentimes 5 years prior to the transplant, so we want to make sure that we're outlining what's expected from them and their families. Really, we're going to be going into the basic demographic and family structure. We want to make sure that we secure a support person for assistance after the surgery. It is quite a bit of follow-up in regards to lab work and medical appointments, and they will be mobily limited to a degree due to the abdominal surgery. We also assess them for any DME they have at home, things including canes, walkers, any assistive devices, and community services, including home care or any other kind of HRA benefits, HASA benefits, housing in general. We do go in depth with the substance use histories as well, just to ensure that there are no issues that we need to work with them on that could impact their adherence post-transplant. We go over dialysis histories and medical compliance, and as well look into their mental health history to see if they need further evaluation from any of our psychiatric team members. Housing stability is big for us as well. We want to make sure they have somewhere safe and stable to recover from the operation so that there's no risk of increased exposure to public. We don't want to have them in a situation where they might be at higher risk for infection. And then we do briefly go over the financial stability. It's very likely they'll be out of work, maybe applying for FMLA or short-term disability. We want to make sure that they are understanding of the costs associated during recovery.
So what are the next steps after the initial evaluation? So first, we determine at our multidisciplinary team meeting whether or not the patient is a candidate for transplant. If it's a yes, then we move on to the next steps and we start the workup. So that is comprised of cardiac evaluation. So that includes an echo, a stress for some patients, and some patients will require a cardiac cath. Many patients that also get a CAT scan of the abdomen and pelvis. This is important for our surgeons to be able to see the landmarks and see that the patient is surgically an appropriate candidate. Next, we look at the age-appropriate cancer screening. So colonoscopy, pap smear, mammogram, and we also check PSA for the male patients. PFTs are checked, especially if someone has a respiratory history or a smoking history. And then we do consultations with our colleagues in other specialties, depending on the need. After we get the patient listed or while they're in the process of getting listed, we do reevaluate them every 1 to 2 years based on their complexity, their comorbidities, and their medical history, just to touch base to make sure that, one, their workup is up to date, but also that they are still a transplant candidate. So our aim is to have the evaluation completed within 90 days, but this depends on many different factors. So some common things that can impact this timeline is especially the patient motivation. So that's probably number one. So we encourage the patients to, work with us, try to move forward. We're trying to schedule the testing as quickly as possible, but also on their end, they need to comply with the appointments and move forward, because sometimes some of those appointments are very hard to reschedule. The number of tests will also sometimes cause delays in the timeline. So sometimes when we do one test, it brings up some certain abnormalities that need some further testing. So for instance, if they get cardiac testing and they have an abnormal stress test, then they will most likely need a cardiac cath, and so that will extend the time for cardiac clearance. If there's a lot of cancellations and no-shows, that's also going to significantly delay the workup. And so at those points, when we see many of those, after we've helped the patient to reschedule the appointments, typically one of us will reach out to the referring nephrologist or dialysis center or the social worker, the dialysis center, to ask, what's going on. Is the patient still interested in transplant? And sometimes because they know you better, sometimes a helpful word from your side will help encourage the patient to move forward. The cancer screening tests, some of the insurance is requiring dental screening, so sometimes that can also put a little bit of a delay. And then, as I mentioned already, if they require any interventions as a result of their testing, such as if they warrant any cardiac intervention like a CABG, or if they have a substance abuse, an active substance abuse history that requires them to complete a program, those are things also that can move this timeline. So what are the criteria used to determine candidacy? So our basic inclusion is that the patient has to be ESRD, so either on dialysis, or they need to have a GFR of less than 21. They also need to have a projected survival of at least 3 to 5 years after transplant in order to reach the maximum survival benefit of a transplant. And then also their age should be less than 80 at the time of listing. This is chiefly because typically after the age of 80, the risks outweigh the benefits, and so it potentially can cause more harm to a patient, or they may not get the maximum survival benefit. So this quote's a very important quote to take note of. Because donated organs are a severely limited resource, the best potential recipients should be identified. The probability of a good outcome must be highly emphasized to achieve the maximum benefit from all transplants. So some absolute exclusion criteria for transplant. So if the patient has severe terminal neurological, heart, vascular, lung, or liver disease that limits survival, that can limit their ability to qualify for a transplant. But it is notable to say that we are doing now more transplants with our colleagues in other areas within transplant. So with our heart colleagues, our pulmonology colleagues, and hepatology colleagues. So we are also increasing and seeing more patients who are eligible to qualify for both combined organs. So heart, kidney, lung, kidney, liver, kidney. So this portion, if they qualify for the other organ and they qualify for the kidney, even though they have these severe diseases like with heart or lung or liver, they may qualify for a combined organ. If they have current or recent cancer diagnosis, so this is also an evolving area. This is a very kind of evolving and controversial area within transplant. And depending on the type of cancer, these patients may not require minimal wait time, or sometimes no wait time, or they might need a few years of waiting time for us to consider them. So this cancer diagnosis is kind of dependent on the actual cancer and the extent of the disease. If they have active alcohol or substance abuse, we will try to work with them and get them referred to appropriate treatment programs in order to see if they will be able to complete that in order to be a better candidate for transplant.
And the key word is active there. We will work with them further, but there's just extra steps involved.
If they had unstable psychopathology that could impact their survival or compliance post-transplant, they may not be a candidate. Adherence is very important, and so if they have repeated issues with non-adherence to their treatment regimens, then this patient may not be a candidate for transplant, especially because one of the biggest things that we review with them is that they have to be complying with their transplant medications, because that's what helps their transplant continue to survive and for them to get the maximum benefit out of it. If they have severe frailty, and we see that this is a situation that is not going to improve, then those patients are not a candidate. And then as far as social support, you wanted to touch on that.
So we really mean utter lack of social support here. We work with the patient quite in depth just to see if we can identify any friends, family, that are able to assist them. We educate them that this is not a 24-hour care situation and that we really just need more support around the days that they have appointments during the first month of their recovery. It's important that somebody's checking in with them as well, especially if they live alone, just to make sure that they have what they need in terms of like their new dietary guidelines, clear hallways to avoid fall hazards in the house, and just general support with their daily activities. And then undomiciled and shelter resident, I spoke a little bit about this on the slide with the social work recovery. We really just want to make sure that they have a stable living situation. Shelter environments are very dirty, overcrowded, and can be unsafe. We also have difficulty delivering post-transplant medications to these facilities. So we need to make sure that they have somewhere that would be adequately safe for them, up to date on their rent. And we would really prefer something that wouldn't be considered overcrowded.
Some of the other relative exclusion criteria or risk factors, if they have mild to moderate neurological, heart, vascular, lung, or liver disease, if they have an elevated BMI, we do have a potential cutoff of 40 over here, but when they're around that range, we typically will defer to our surgical colleagues to determine if the patient must lose weight before to be appropriate for the surgical side, or if they're acceptable where they are.
So not every BMI of 40 is distributed the same way on the body. So if we can find our surgical landmarks and we feel that the patient's wound healing risk is not overly detrimental based on the elevated BMI, then we will consider them for candidacy. We encourage patients to try to lose weight and have a healthy lifestyle in conjunction with their transplant journey at all steps. But we try to use 40 as a screening criteria just to have in our minds the habits that the patient's going to come in with and what the concerns might be with that patient.
So psychosocial financial barriers, some of them may also increase the risk of transplant. And so if it's not something that's able to be worked with a patient on, then they may not be a candidate. If they have active autoimmune disease, so if they're having frequent flares of their autoimmune condition, then we would need them to have a good stretch of time, usually at least 6 months to a year, where they're not having the flares to show that the disease is in control, because otherwise there's a risk of causing harm after transplant or recurrent disease. And then again, we already talked about the history of noncompliance. How we track this is through communicating with our dialysis center staff colleagues to see how well they're attending dialysis, and then also to see how well they're attending their medical appointments. If they are missing a lot of dialysis, they're having frequent hospitalizations because of missed dialysis, and they're missing many medical appointments, then those are certainly red flags in terms of compliance for us. So with all this being said, please don't allow the patient characteristics or risk factors to deter you from referring the patients who are interested in transplant over to us. Our role is to help you with those tough questions and decisions, and some of the patients are very complex, and we're happy to help, educate and determine whether the patient is truly a transplant candidate. So how can we increase the chances that our patients will be transplanted? So I think communication is the most important key here. So we will communicate with you when the patients are referred and evaluated. We'll also relay any significant new information and results of abnormal tests during the evaluation. If we have any concerns about the patient, we'll reach out. And certainly when there's changes in the patient's status on the list, when they're activated versus inactivated or removed from the wait list. You're receiving quarterly reports with all of your patients and their transplant status, and then you'll be notified when the patients are transplanted as well. So our overall goal is to be supportive and available. We want to be here to help you take care of our patients together. And we have dedicated outreach and coordinator staffing here that are available by phone or email to answer any questions or concerns. On the other side, when we are notified by you or the patient of any status changes, whether it's an extended hospitalization or any serious medical issues, we will work to determine whether the patient needs to be inactive on the list or whether they are no longer a candidate for transplant. So why is this important? So this is very important because any delay in inactivating or removing patients that are not suitable for transplant on the list can potentially cause harm to that patient. So if they are too sick for transplant and we try to transplant them, they may get more sick. And also this can delay other patients who are suitable to get the organ offer from getting the offer because they might be lower down on the list. So in terms of our living kidney donor program, so first, what is living donation? So why living donation? So living donation has improved survival over the patient staying on dialysis. And this is the best form compared to a deceased donor in terms of having the kidney work faster, have less complications, and have a longer survival benefit for the patient. They don't have a lengthy wait time on the list. It's easier to plan for surgery and recovery because it can be controlled and scheduled to be suitable for both the donor and the recipient. Generally, it's safe for the living donor when these patients are carefully screened. And it's notable that all of our living donors go through their own separate process and they have rigorous screening. They see the different providers, surgical, medical, social work, psychology, and then they also get their own separate evaluation, including blood work, urine studies, and imaging. There are options in living donation, even if the potential donor isn't a specific match by blood type or immunologically compatibility with the intended recipient. So if the donor is considered to be a suitable donor, but just not a good match for that particular recipient, we do have options such as swaps that can be utilized in order to still get that survival benefit from getting a living donor. So who can be a living donor? So basically anyone who's at least 18 years old and mentally capable of making an informed decision. If they have a measured eGFR collection of at least 80 milliliters per minute, and if there's no overt evidence of any kind of coercion or financial compensation for a donation. So things that would exclude a living donor is if they have uncontrolled hypertension, diabetes, obesity, more so with a BMI higher than 35, if there's any evidence of coercion, if they have any history of current or recent cancer, if they have active alcohol or substance abuse, if they have unstable psychopathology, if they have any history of multiple kidney stones, or if they have a history of significant proteinuria. So there's no cost to donors. This is very important to note that the donor's medical workup, surgery, and direct post-operative complications and care and hospital stay, that's all covered by the recipient's insurance. Transportation and lost wages are not covered, but could be reimbursed. They may have to go on short-term disability, but it's important to emphasize again that donors cannot receive compensation for the organ donation. They could be faced with a large fine or time in prison if that is confirmed. So once a donor evaluation is completed, our multidisciplinary team meets to weigh the risk factors and determine whether or not the patient is a suitable donor. Again, taking into account their entire workup and everyone's perspective who evaluated the patient. And then the donor's candidacy is determined without regard for the recipient. So we realize that this is a voluntary procedure for the donor. We want to make sure first and foremost the donor will not be harmed in this process. So we exclude consideration of the recipient when we are considering a donor for donor candidacy. We have a wonderful tool that we have recently started utilizing called Live and Let Live. So this is an online tool that's available for the community. And what they do is they go to this website and they can apply to be part of this campaign. So this is for anyone anyone donors who would like to donate altruistically or donate through this avenue. And also recipients can also go on here as well. So this is a way that we have utilized and recently started seeing benefit from to help try to increase living donation for our patients.
And then these are our evaluation locations. We currently have 2 sites in the Bronx. 1250 Waters Place is a larger facility with a lot of extra parking if patients prefer to drive. We do see patients in Elmsford and Westchester now, just above White Plains. And we're also opening up our clinic once a month in Nyack to help and serve the community in that area. If you have any questions, you can always call our transplant center. The number is listed there. And alternatively, you can reach out to either Joan Gooden or myself via our cell phones if you have questions for any of those areas also.
Thank you for your time. We're happy to take any questions.
Thank you so much. I wanted to first address one question that's in the chat. The first one was, how can we be provided with the exclusionary list for Montefiore? So the first way to get the list of criteria that I'm familiar with that I can share is Montefiore has recently been loaded into Kidney Transplant Compare, a collaboration between or an offering from the network, but they've collaborated with us to share information about their transplant center so patients and providers such as yourselves can access information. But I wanted to extend this question over to the transplant team. If a dialysis facility wanted to get access to an exclusionary list, where can they find information on that?
We could send it to you to distribute to people, those on the call, or you can always call one of our outreach coordinators and we can get that to you.
Wonderful. Thank you so much.
Carolyn, if you don't mind, you can put my email in the chat. It's not letting me enter.
Perfect. Okay. And then the next question was, if we wanted to reach out and have a representative come to our clinic, are the outreach coordinators the appropriate contact?
Yes, if you could just email me and provide the clinic that you're looking for, we can start talking about that.
Are there any other questions? Anyone that wants to come off mute and ask the transplant team?
Carolyn, this is Vicky. I was just curious if a patient's able to assemble like 2 or 3 people who say they would be willing to kind of share responsibilities to support the patient. Is that acceptable in your criteria as a support person?
Yes, but that happens very frequently. So people are restricted by their work or family responsibilities. So a lot of the time our patients may isolate one person for the first week, another person for the second week, or just split up responsibilities in regards to helping the patient at home, and then one person helps them with their appointments. Absolutely, we can coordinate with them.
And I could answer the question. It says, are there any charitable or hospital resources to help patients who are traveling? The first thing I will say is that we are screening patients for social determinants of health. So, for example, if a patient has food insecurity, housing insecurity, or something else under social determinants of health where they are flagging, Montefiore now has 26 community healthcare workers, and what we do is send a referral to them, and they will, if the patient agrees, they will reach out to them to see what types of services and resources they can help them with. We also have a specific abdominal transplant fund. It's called Helping Hands. And that is a resource for patients that are in urgent need. Occasionally, we may pay a utility bill or help someone with transportation, but that is something that we have available for our patients. Do you have anything to add to that? Okay.
So social workers would typically assess with the patient and evaluation as well, just to see if there is any other community resources. But some of them are a little more difficult to get into, so that's usually sussed out when we meet with the person face to face.
Wonderful. And then the next question is, do you do kidney pancreas transplants at the same time?
That's a great question. So we do kidney pancreas transplants. We're one of the largest in New York State. And this is a great benefit for those patients who qualify for it, because it's a shorter waiting time because less patients qualify for it. And especially for the patients who have, good functional status, they're in the appropriate BMI, they show that they don't have concern for insulin resistance, which would make them not a benefit from the pancreas transplant. So if they don't, they fall into the acceptable criteria, and SPK is something we definitely evaluate for. And actually, even if the patient is referred to us for kidney, that they have a history of diabetes, we will evaluate whether or not they might be a candidate for simultaneous pancreas and kidney transplant.
Wonderful. Thank you so much for that. The next question, it says, I'm a new social worker at DaVita Queens. Is there a contact person who I can check patient status with to see where they're at in the workup? Is it better for them to contact the general phone number or an outreach coordinator?
Stephanie, you can email me to start off, and we can go from there.
Wonderful. Any other questions from our attendees today? Perfect. The next one is, what is the biggest challenge that your program has at this time? I may be able to reword that if there's.
One of the things I would say, and I know there's probably, but again, when it comes to patient motivation, I think that is a big element, because if a patient's motivated and they say they want to get their testing done immediately, we can get that set up. One of the biggest challenges we have is with cancellations and no-shows for patient testing. And so that inevitably drags out the evaluation process. The other thing is just, if the patient does have a lack of resources, it does take time to work through that. But if a patient's motivated and they want to get on the fast track to move through this, we will definitely partner with them. Do you all have anything else?
Yeah, so I want to be clear that the 90 days is not like a mandatory timeline as well. It's what we strive for. Everybody has different barriers that they may be having issues with. Some people's jobs are a little less lenient on taking time off for medical appointments, things like this. So yeah, patient motivation again is huge, but I just want to be clear that the 90 days is not a mandatory timeline.
And it's important to know that the patients better. So if we see that there are substantial amounts of missed appointments, we will reach out to the patient's, nephrology and dialysis team to see if there's a reason why the patient is not coming. Sometimes there is a reason, whether there's a family obligation or transportation that we can hopefully work with them for, and sometimes they are truly not compliant. So it's important for us to weed out those different situations in terms of the compliance.
We also really encourage every potential candidate to identify a living donor or a set of living donors. That's as Dr. Panetta mentioned during the presentation, that's the most rapid pathway to transplant with the longest surviving graft and patient survival as well. So sometimes it's digging deeper and asking tough questions. We're here to support the candidates and start those conversations and identify people in their social circles or their family and friends who can come forward as living donors. And I think some patients struggle with not wanting to ask for that kind of help. And we understand that as like fellow human beings, it's a hard question to ask, but it really is the best pathway to transplant for any patient. So we're here to help them find living donors.
Yeah, reaching out to our living donor team just to get hints and tricks on how to maybe conduct that conversation and just get a little coaching on how to move forward in the best way is also something we would encourage, even if they decide not to go through with that process.
And then one other point in terms of post-transplant care is sometimes for our patients who are a little bit farther north, coming down to the Bronx is a little bit difficult for them. So now we have the option of doing post-transplant care over at our Westchester location. So a few of us do go there once or twice a week to do post-transplant care. We do tell them in the immediate time after transplant, like within the first 3 months, they will be coming to the Bronx, only because we have our entire transplant department there. So during that first 3 months when they may need more close watching and they might need, closer care in terms of if they need to be directly admitted or anything like that, we have those resources there. But once they're stable and past that point, we're happy to see the patients in another location like Westchester, where it might be a little bit more of a more convenient location for them.
Great information. Thank you, guys. The next question is, where are we at? Are there any resources for a dialysis center that has a larger number of undocumented or emergency Medicaid patients?
So this is I will say this is a really tough question to answer right now, as what happened a few weeks ago or a couple weeks ago. I will say what we are trying to do, and we're trying to expand this currently, is to provide access to free or reduced cost legal services, because ultimately if that patient has a pathway to getting some type of status that will allow them to get regular Medicaid, that is absolutely what we want to do. So more to come on that. We would love to have, we're ultimately wanting to have availability for patients to have access to this every week. But it's just kind of difficult to really flesh out, because one of the things is that the patient has to be willing to talk about this. And at the end of the day, they're worried because there's a risk. And so it's trying to figure this out. I mean, we're one of the fortunate few states that offers dialysis under emergency Medicaid. I mean, there are 40 states in the country that don't even cover dialysis for emergency Medicaid. It's very unfortunate. But once we get this more, we can certainly follow up with the dialysis units on this.
Thanks for that. I think that highlights a few slides back where if the patient is interested, it's recommended to refer them and allow the transplant center to go through the different patient-specific criteria to see if they're truly a candidate or not.
And I just want to give a reminder, if some of the people on this call aren't aware yet, but patients that are age 65 or older now can qualify for a full Medicaid plan regardless of their immigration status. We do encourage them to still put extra thought into support and financial service, just because a lot of those patients won't be eligible for state benefits past that.
And just one final thing to say is that honestly, it has nothing to do with the person's immigration status. Absolutely not. What it has to do is just ensuring that we're not causing a hardship by transplanting a patient. And when you're considering this, them having financial clearance and having adequate insurance and adequate ways to cover their medications post-transplant is what we're worried about. It is absolutely not anything to do with their immigration status.
Thank you. And then, Luke, it looks like there was a question to repeat the Medicaid for 65 years and older. There was trouble hearing it.
Oh, yeah. So you can find this online. So basically, if you're undocumented, you're able to apply for a full Medicaid profile if you're 65 or older.
Thank you so much. Um, the next question is about support service offerings. Where do patients' families usually stay if they're from a different part of the state? So this is like the support person. And then also, where would the patient stay after transplant because of frequent visits post-transplant?
So one of the things I would say is we do have some limited hotel space that comes at a lower cost than a hotel that's available if somebody is staying a minimum of a week at a time. It just has to be coordinated. That is something potential. But we, so if you can think about this, the first month after transplant, they need to be seen weekly and also have labs. So what we are talking about is a weekly visit for a month. And so I think it's going to depend on whether somebody's going to be able to do that. There is going to need to be advanced planning. But, outside of the potential for the hotel space or a hotel, what the person would need to do is plan for a weekly visit. Some people can do that if they live a couple of hours away.
And I will also say, depending on the insurance, there's some that are commercial insurances that will pay for travel and lodging depending on the mileage.
And I just want to delineate here that it's lab work and a doctor's visit. So it's really twice a week that they'll be coming to the facility for the first month.
The lab work could be done. Look,
No,
oh,
not
no.
the first.
Okay.
And then the next question was, do you have any software that allows bidirectional communication between ESRD facilities and your center? This would be referral and then communication throughout the referral, waitlisting, and transplant process.
We don't have specific software, but we do have some providers who have access to Epic, and now we have Epic Chat into our Epic system. So I know that there are some outside providers who have messaged me through there. So that's been a great way to communicate.
You can also refer, if you go to the website, that's an electronic method of communication. If you prefer to do that over a written referral.
Sounds good. Thank you. And then the other question was more just a request. In addition, possibly follow up from this call to providing like the inclusion exclusion documents. I know we have contact information on the slide deck currently, but if there's also a contact sheet that we could share, but I will coordinate with you guys for follow-up material to see if this is the best contact information or if there's something additional that we can share with the community. The next question, it says, in terms of recovery for the donor, what does the recovery typically look like for them? So this is someone who is a living donor.
The patients will stay at least one overnight in the hospital. Most patients stay 2 overnights so that they're fully ambulatory, they're eating, they're drinking, they've been able to urinate successfully after the surgery. Not required to have a bowel movement, but we like to see a bowel movement before they're discharged. And then beyond that, as an outpatient, it's highly person dependent. Most patients sort of feel like themselves within 6 weeks from the operation. The operation is designed to be an ambulatory procedure, so it's not meant to have long-standing or chronic sequelae. Most patients take about 4 to 6 weeks to start feeling like themselves again. And return to work obviously depends on what they do. If it's strenuous activity, heavy lifting, a lot of robust movement, then they should probably stay out of work like closer to 2 months. If they do something that is seated and less intense, then they can resume it as soon as they feel well and they're not taking any narcotic pain medication.
To add to that, just to reiterate that at no time is there any part of the evaluation that will come out of pocket for potential living donors. There are a couple of different donor assistance coverage opportunities that will help pay for time off work, transportation, hotels, and the like. So it's a really great thing for people who have potential living donors, and those potential living donors can be remote friends, neighbors, cousins, spouses, anybody that can be considered.
Wonderful. All right, we are just a few minutes until the end of the call, so I wanted to ask one more time if anyone who is an attendee today has any questions for the transplant team, and if the transplant team has any questions for the attendees, feel free to unmute or put it in the chat.